Welcome back, students, to part 87 of our IPDRG Masterclass. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Now, in part 86, we covered the intricacies of MDCO1, diving into neurosurgery and spine procedures. Today, we're shifting gears. We are going to demystify the MSDRG system by really digging into the anatomy of a claim. And our specific focus today is major diagnostic category 06, diseases and disorders of the digestive system. This is literally one of the largest inpatient diagnostic categories out there. We're talking about everything from upper and lower GI pathologies like severe hemorrhages all the way to complicated ulcers. Okay, let's dive straight into today's syllabus. We'll be hitting the MSDRG architecture, principal versus primary diagnosis, severity multipliers, present on admission indicators, clinical documentation improvement, and finally, real-world coding scenarios. Section 1, the MSDRG architecture, the core framework. So what exactly is an MSDRG? Well, it's a statistical system used by CMS to classify inpatient stays. Think of it as a giant sorting mechanism. The core formula here is pretty straightforward. Clinical similarity plus resource similarity equals one payment group. Basically, every patient placed in a specific DRG is expected to have a fairly similar clinical profile and consume roughly the same amount of hospital resources. In our world of MDC6, this means the system groups patients based on whether they need strictly medical management, like for inflammatory bowel disease, or if they require an actual surgical intervention, like a gastrectomy. Now, this system didn't just appear out of nowhere. It evolved significantly over time. Back in the 1980s, Yale University developed the original DRG model, which honestly mostly grouped cases just by the principal diagnosis. It was pretty basic. But fast forward to fiscal year 2008, and CMS introduced the modern MSDRG system we use today. The absolute game changer here was that the new system explicitly differentiates cases by severity of illness and comorbidity. To make these incredibly complex payment determinations, the MSDRG grouper, think of it as the logic engine, relies on 5 key inputs. We've got the principal diagnosis, secondary diagnoses, principal procedure, secondary procedures, and patient demographics. These inputs are exactly what partition cases into either medical or surgical DRGs. So, for our focus area of MD06, the logic engine uses these details to distinguish between, say, a medical admission for a GI hemorrhage or gastroenteritis versus a surgical admission for something like a colectomy, an appendectomy, or a hernia repair. Moving right along to Section 2, principal versus primary diagnosis, driving the claim. Now, this brilliantly illustrates a really common point of confusion. You have the primary reason for admission, which is basically the chief complaint on day one. Let's say a patient comes into the ER complaining of exquisite right lower quadrant abdominal pain, maybe some nausea and vomiting. That's the symptom. But then you have the principal diagnosis. This is the final confirmed diagnosis after all the imaging and lab work is done. So in our example, that would be acute retrocecal appendicitis. That level of precision in anatomical localization is exactly what drives accurate MDC assignment. And here we have the official coding guideline definition of the principal diagnosis. It is the condition established after study. That phrase is absolutely crucial because it dictates the entire major diagnostic category. If a coder mistakenly assigns the initial symptom, like that abdominal pain, as the principal diagnosis instead of the confirmed appendicitis, the MDC will be wrong. And if the MDC is wrong, the entire MSDRG will be completely incorrect, which almost always means the hospital gets underpaid. All right, Section 3, severity, CCs and MCCs. These are your payment tiers. Now, what's really interesting about this setup is the visual breakdown of the DRG triplet structure. The presence of secondary diagnoses is what triggers these different tiers. At the absolute bottom, you've got the base DRG without any CC or MCC, yielding the lowest relative weight. But if you have at least one secondary diagnosis flagged as a CC, you bump up to the middle tier. And if you have an MCC, a major complication or comorbidity, you jump all the way to the highest relative weight and consequently the highest reimbursement bracket. Let's look at the clinical reality of this logic. A CC adds moderate severity. Think about conditions like general anemia, a standard UTI, or mild malnutrition. An MCC, on the other hand, indicates extreme severity and massive resource consumption. For instance, looking at our MDC06 GI hemorrhage cases, if a patient develops severe hypovolemic shock or acute tubular necrosis rather than just a standard prerenal AKI or maybe severe protein-calorie malnutrition, these are critical MCC targets. Capturing them drastically alters both the clinical picture and the facility's reimbursement. Which brings us to the plot twist. Section 4, Present on Admission, or POA. POA indicators basically give us the context of when a condition actually kicked off. These are required reporting elements. Y and N indicate whether the condition was present or not at the exact time the admission order was written, while U and W account for those tricky situations with insufficient documentation or clinically undetermined scenarios. Here is the absolute high-impact rule you've got to remember. Under the Deficit Reduction Act policy, if a secondary diagnosis is deemed a hospital-acquired condition, meaning it's flagged N for not present on admission, it generally cannot be used to increase the MSDRG payment, period. So, if a patient comes in for a GI bleed and 3 days later develops a severe catheter-associated UTI, yes, that UTI is an MCC, but that N flag absolutely nullifies its ability to bump up the payment tier. Section 5. Clinical Documentation Improvement, Bridging the Gap Between the Chart and the Code. When clinical documentation is ambiguous, incomplete, or missing a POA status, coders must step in and query the physicians. There are some incredibly common triggers for this. For example, if a physician just jots down anemia, the coder literally cannot stop there. They need to know the exact etiology. Are we looking at acute post-hemorrhagic anemia from an active GI bleed, or is this just chronic iron deficiency? Payer audit denial defense relies entirely on this specific clinical validation. You have to track acute drops in hemoglobin and hematocrit, or note the administration of PRBC blood transfusions to back up the claim. So the crucial point here is how you legally formulate that query. HIMA and ACDIS guidelines are very strict. Queries must be non-leading. You absolutely cannot say something like, patient's hemoglobin is 6.2, can we code this as acute blood loss anemia? That is illegal because you're suggesting the diagnosis to the provider. Instead, a compliant query sounds more like, patient's hemoglobin is 6.2. Can you clarify if the anemia is acute, chronic, or due to another cause? You provide the clinical indicator and you ask an open-ended question. This compliant, non-leading formulation is your facility's primary defense against commercial payer denials that constantly try to reclassify acute blood loss down to a chronic condition. Finally, Section 6, Real-World Coding Scenarios, Applying the Rules. Let's see how this all builds together. Now, we are looking at a respiratory group or flow for DRG 193 here, but the exact same mechanical logic applies seamlessly to our digestive categories. Your inputs create the base DRG, your secondary diagnoses add the MCC to boost it, and a negative POA flag can drop that payment tier right back down. Now, applying this directly to our digestive system focus for MDC06. Say you have an upper GI bleed, and the physician performs an EGD, an esophagogastroduodenoscopy, with biopsies to inspect for ulcerations. That specific endoscopic diagnostic link is coded as OD38ZX. Whether it's an EGD diagnosing esophageal varices or a colonoscopy finding diverticular bleeding, that endoscopic diagnostic link is totally critical. You must distinguish an active clinical hemorrhage from historical trace blood loss to select the correct principal diagnosis. This level of precision is what ensures accurate assignment into the proper medical or surgical DRG partitions. So, ask yourself, when the auditor knocks, and they will knock, will your facility's clinical documentation stand strong, or will ambiguous notes cost you your rightful reimbursement? Today, we mapped out the logic of MDC06 medical DRG grouping, we tackled GI hemorrhage coding rules, and we broke down the vital criteria for acute post-hemorrhagic anemia validation. In Part 88, we are going to explore the advanced surgical DRG deep dive for MDC06, covering colorectal, upper GI, and abdominal surgery. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep coding with precision, and I'll see you in the next explainer.